good morning, good afternoon, and good evening, everyone. Welcome to another week of Global Cafe. My name is Natalie Mystery, Senior Policy and Project Coordinator here at the IFA. And today I am very excited to be introducing you all to Professor Patrice Forget on the topic of the impact of pain in aging populations. And this is as part of IFA's new three-part Global Cafe Pain Management series in partnership with Halion. So, Professor Patrice Forget is clinical chair in anesthesia at the University of Aberdeen in the United Kingdom and honorary consultant at the NHS Grampian. Until 2019, he worked as clinical professor in anesthesia and pain medicine in Belgium and as president of the Belgian Pain Society. He is involved in clinical research focused on mainly perioperative epidemiology, pain, and clinical pharmacology. For the last 15 years as principal investigator and/or the national coordinator, he has authored more than 200 publications in peer-reviewed journals. He founded and chairs the Pain and Opioids After Surgery, or PANDOS ISEG research group. And Patrice Forget received speaker and advisory board honoraria from Grunenthal, GE Healthcare, and On Comfort. He is also a board member of the European Pain Federation, chair of the Societal Impact of Pain platform, and of the Pain and Opioids After Surgery Research Group, deputy editor-in-chief for the European Journal of Anesthesiology, and also a senior academic associate editor for the British Journal of Anesthesia, BMC Anesthesiology, and the Journal of Clinical Medicine, Critical Care, and Pain Medicine, and expert for governments, scientific organizations, Cochrane, and REDCap Consortium member. So thank you so much for joining us today, Professor Forget. We are honored to have you.
Thank you. Thank you very much indeed for the invitation, because it's really a pleasure to interact with you, with people, to also sometimes challenge views. The goal is simply to be patient-centered and to be sure that we offer the best service together. Also, sometimes identifying knowledge gaps and maybe influencing research agenda when needs are identified and when we do not have solutions. Fortunately, we have some, so we'll discuss that, and that's all about pain assessments based on existing knowledge, and we'll probably have the opportunity to discuss that. And finally, coming up with the so what? So what does it mean to me, or what does it mean to my patients? What will I do differently during the coming week?
Absolutely. So I just kind of want to start off our conversation by, given your expansive involvement in the field of pain management, as we listed kind of all the different various organizations and things that you're involved in, I'd love to know what brought you into the career path that you're currently on right now, and what has inspired this passion to help people navigate their pain better.
Oh, that's kind of personal question, but that's interesting, because it also probably mirrors, or my own journey mirrors the the evolution of pain medicine, pain management, pain science during the last 2, 3 decades. So knowledge from more than 2, 3 decades was probably 60, 50 years, and from Melzack and discovery of gate control theory, and um, the the existence of pain pathways that could be directly modulated and better understood, but also modulated not only by intervention, but also modulated by other systems in our body, and how we can also understand the interference between psychosocial aspect and neurophysiology, and how all what happens in our life may have, to some extent, contributing effect, positive or negative, in the way we cope with pain. And then during the last 2, 3 decades, I have seen the golden age of pharmacological treatments, and then realizing that it's not only about pharmacological aspects and use of molecules, because otherwise it would be not only potentially harmful, but also just the quality of pain management isn't necessarily the one we would like to see, and then sometimes just pain just may persist even if the an appropriate dosage of medication has been found. And then my own journey came from clinical pharmacology to progressively the safety side, because identifying all the problems that we have heard about um, inappropriate use of opiates, but even if appropriately used, then they may have some side effects and limited efficacy anyway on the longer term, to the safety side then, and then to health service research and how to offer the best service we can to patients suffering from pain, living with pain, uh, not only on a neurophysiological point of view, but also on a psychosocial a point of view. And then the next step, and my own research program, which is called Pain and Opiate After Surgery. So the PANDAS research group um implementing the PANDAS research program is about implementation studies, implementation research, how to better apply the guidelines, how to better deliver educational programs, just to try to help people better managing pain. And pain is first managed by patients, of course, but in terms of healthcare providers, by non-pain specialists, uh, much more than by pain specialists. So I'm very happy then to get views and to be sure that what we do is right, or how we may improve things, to be sure that we all well equipped to improve the quality and the safety of pain management.
Thank you for sharing all of that. It's absolutely important to continue to improve the type of care, the thought that goes into the management of pain. And so thank you for being part of this field and sharing your thoughts with us
Mhm.
today. And so to help us better understand what exactly pain management is, could you introduce a little bit of the science behind pain and why we might feel it? And maybe what are some of the mechanisms within the body that are kind of involved with that?
Absolutely, yeah, and that's a so I have the luxury to speak about that on the shoulders of giants who have worked so much during the last few decades, and now we have quite a much better understanding on what we speak about when we speak about pain. And the International Association for the Study of Pain, IASP, now distinguish quite clearly described mechanisms, and we may speak about, let's say, classical pain, so nociceptive pain, which can be linked to mechanical issue, about trauma and inflammatory pain. So just nociceptive pain, which is not related to dysfunctioning pain system, nerves, or um, central nervous system. So it can be at the periphery of or at the central nervous system. So is if this is dysfunctioning, if lesions are identified, and there may be different mechanisms, but then we speak about not about nociceptive pain, but neuropathic pain. So that's the second mechanism. And lesions can be the consequence of um, trauma, of course, including a surgery. It can be chemical, can be other um, type of lesions, can be infections as well. Let's think about the herpes zoster pain. So all these nerve lesions may induce neuropathic pain. And then a third mechanism, which has generated a lot of debate, is nociplastic pain, which is something that was called maybe in the past functional pain, or when we didn't know anything about that, then it was supposed to be psychogenic or thing like that. Nociplastic pain is then when the pain can show an exacerbated response to a normal stimuli in a non-lesioned nervous system. Uh, an example in widespread pain syndrome, it can be about fibromyalgia, uh, for instance, but it can be of in different situations, including in continuous severe stimulation, and then that's that's quite problematic in many people, especially when aging is accompanied with daily pain. That can be something that may impede capacity of people to cope well with pain. Uh, We'll speak later about solutions and a possibility to cope with, but an example of what we know that doesn't work, unfortunately, for that is, for instance, high dose of opiates for pre- in with the idea to prevent that kind of sensitization to pain. Opiates, in fact, can be counterproductive because we know that the opiate-induced hyperalgesia is, to some extent, an example also of iatrogenic central sensitization that can happen. So then we have a number of mechanisms. So I have mentioned nociplastic, neuropathic, nociceptive. That can help also trying to be mechanism oriented when we speak about pain treatment or prevention of pain. So that can be a kind of summary of the last 50, 60 years of pain research. And that can be practically very useful at the bedside, just to think about, okay, that's that kind of pain. That will be probably the best treatment for, um, yeah, uh, improving outcomes. Probably we will discuss about what kind of outcomes later on.
Absolutely. Thank you for providing that really concise summary of, the science behind pain management. I'm sure there is an extensive amount of years of research, as you mentioned, going into that. And so I think it might be, it's really helpful to at least know the basic, parts that are associated with that. So thank you for sharing that. I kind of wanted to ask you if you could highlight the burden of pain. So including like the prevalence and the impact on the quality of life, specifically with aging populations.
Yes, so that has been another field of research um, where knowledge has massively improved. Basically, what we can say is that the one person on five in the Western world suffers from a chronic pain. So that's quite a big burden. If we look at the international burden of disease study pain, and especially spine related pain, neck pain, and low back pain, but also pain linked to osteoarthritis is definitely among the top of the list of burden of disease. So 1 on 5. Fortunately, not everybody suffers from severe pain. That's good. So we have also to be quite careful not to over medicalize pain, which is to some extent something that can happen in our uh, um, life of all of us, but 50% of these people suffering from pain uh, may suffer from severe pain. That can directly impact quality of life, and that's important to recognize that. And then in that situation, we have two entities, and then pain can be seen as a symptom of another condition. And so, of course, that's important to be etiological and to look at why is this pain happening? Could we have an impact on the source of pain and the cause of pain? But in many situations, also pain can go further and not resolve, even if the initial cause of the pain may have disappeared. It can also happen on its own, primarily, so primary pain, and but that's important to recognize this existence of pain as a potential symptom of conditions, but also pain as a disease on its own. And of course, some people may have more vulnerability factors than others to develop chronic pain, but also maybe just to suffer from uh, pain more than others and to cope less well. And then so that's important to recognize the interference of psychosocial aspects, and considering that pain severity is not only about pain intensity, but that's also about interference, physical and social interference, and then finally coping, psychological distress, and with that we can cover quite a clinically useful definition of pain intensity and think about not only about mechanisms that we have mentioned before, but then what are the consequences of that, and what are patients' goals, which might be different, to be sure that we address issues that really matter for patient or for people living with pain, which are not necessarily always patients, but to some extent they also uh, can be. So 1 on 5, 50% of these with severe pain, and then needing to differentiate pain that can be linked to another condition, a symptom, and pain as a disease on its own. I have mentioned fibromyalgia, and for pain secondary to symptoms, I have mentioned, for instance, post um, epizoster, but it can be diabetic foot or neuropathy linked to any kind of disease, osteoarthritis, and so on. Sometimes it's difficult to differentiate. Mechanisms may overlap, and also pain may start as a symptom and progressively um, persist and becoming a disease on its own. So also differentiating these different stages of the condition may help better address issues.
Yeah, thank you for kind of walking us through that. And that statistic, the 1 in 5, is, quite quite alarming. Um, and I know you briefly mentioned talking about the goals of patients in terms of pain management. I was hoping if you could just briefly touch on that and kind of discuss, what are some of the, like the range of goals of expectations that maybe some of older adults might have in terms of their pain management.
That's yeah, to some extent a $1 million question, but also to some extent relatively simple to address. So going back to what I have said about pain severity being a combination of pain intensity, functional and social interference, and psychological distress or psychological aspect, it wasn't totally naive to structure that like that. That's also because it's the way uh, the last WHO classification of diseases mentions or describes pain. So if you just go um, to the browser, and we have in the chats copied and paste the link for the ICD-11 classification. You may just type pain or chronic pain, and then you discover the different potential diagnoses. And if you click on that, then you can go to the to each definition, and then after that you can have the different components. That's important. So for clinicians, it can be just useful to communicate more easily with patients about the diagnosis, but also the different component of pain, that it's not just about pain intensity, and then to discuss the goals. On another thing, it might be also useful to better collect data about epidemiology of pain, what is the burden of not only pain, but pain diagnosis conditions, and the different components of this pain to try to help the system to better cope with the different issues that people may suffer from, and to better know what matters to people. An example is, what do I do when I see patient, for instance, in my anesthesia life before major surgery, and knowing that maybe the person being 80 may be particularly keen to invest time and energy to quickly recover and to go back home and to be, and then pain related goals might be related possibly to pain intensity, let's say pain scales, pain scores, adapted to the person and how communicating people are, but also about self-efficacy. That might be the end. And in the meantime, what we could do to help people to reach their goal: I would like to go out of the bed. I would like to recover as quickly as possible. I would like to um, be safe and safely go back home, and possibly not going to a care home. Or I'm particularly anxious because my past experience wasn't good. I'm super afraid of being in severe pain, and then it might be possibly something um, that could be differently addressed. So again, about intensity, functional, social interference, and um, psychological aspect. It's often a little bit of everything, but sometimes maybe other people would say, no, 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 I'm anyway coming from a care home. I'm here because I'm in severe pain and I'm going to a surgery which I hope will solve the problem of pain intensity. And it's more about symptom control
Mm.
than recovering because life expectancy is not my goal. I'm not minded to live 10 years like that. I just want to enjoy life better during the next few months. And then knowing or structuring that in our mind, and then when going to the patient, briefly interviewing them and just saying or just asking, yes, but finally, what does matter? What does matter to you first? And what could we offer to be sure that what we offer does match you your goals might be good, and that may change over time. So if we speak about shared decision making, is not just a tick box exercise for one yellow form in the NHS in the UK. That's a yellow form. You have signed a yellow form. It's much more than that. It's about going back to patients. Are you comfy? Are you doing well? Are you doing what would you would like to do um, uh, today? And are you confident that tomorrow will be brighter than today, or that you will get the support if it's not the case? So
Yeah.
that's a way to reintegrate that kind of structured perspective at a system level to very simple clinical or clinically oriented and patient-centered messages.
Yeah, absolutely. Yeah, it's so important to really have that discussion with the individuals themselves and see what their priorities are and what their options are related to their current condition. So it's a lot to consider, and it's probably a very difficult course of treatment plans, care, things like that. But I think it's definitely it's based on the individual themselves and how they're feeling with everything. So with that, I actually wanted to ask, what are some of the most common symptoms and manifestations of pain?
Yeah, so that's that depends, of course, of the clinical condition and how people may communicate. And we know people with cognitive problems or mental health disorder may have different ways to um, communicate or to express their pain, and sometimes just prostration, hypoactive, delirium might be something that can be linked to pain. Technically speaking, when we follow patient and think about recovering uh, from a painful condition, should be associated with some functional outcomes. And it might be about, of course, in quite severe catastrophic situations in secondary care, hospitalized patient, we may think about just, yeah, moving, including breathing, coughing, mobilizing, sleeping. These are the functional aspect of pain that we should think about, and always think about pain when people are not moving well, not sleeping well, not breathing well, not eating, drinking well. So these are the, let's say, the vital parameters that might be consequences of pain. Um, I haven't mentioned first pain scores, even though we know that it has been proposed as the fifth vital signs with unfortunate consequences of that if it's considered as an end on its own. So not meaning that pain intensity is not important, but it has to serve specific goals. Of course, one of these goals might be to address the unacceptability of pain according to the patient. And then sometimes patients say, yes, 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 you're right. It is quite logical to be more happy if I can move, if I can sleep, if I can be more comfortable. But comfortable for me would mean, first of all, considering the fact that pain for me is unacceptable by definition. And in acute pain, it can be quite different, not always the case, but sometimes people with relatively low pain scores consider that it's not acceptable. The opposite might be true also. People may be super resilient, sometimes may not understand that pain is preventable or treatable, and then sometimes may accept a pain that for us might be unacceptable, or might be preventable, manageable, or better manageable. And that does mean that we have to empower a patient and to go back to them and to ask them, uh, what's your a pain today, pain score or pain scale? That's not the most important thing. You may just use a validated scale, and there are plenty of validated scale in your environment with other team member involved in the decision, because that will be also by repeating the assessment that we will have a much better vision about what is currently the pain of or the, yeah, the pain level of the patient, and that may also facilitate communication with the patient. When I say validated scale, the advantage is that then we remove part of our subjective interpretation of the pain, and we try to focus certainly on a subjective parameter. Pain is subjective, but on patient subjectivity first. Even if we cannot totally neglect the interference of our own subjectivity, but to some extent, it's not always problematic. A placebo effect is not coming out of the blue. That's not magic. That's something that we can induce also because we are people working with and for people, and that's also good. So to some extent, it's not impossible that this particular relationship and building trust and so on may have a positive impact, and unfortunately, sometimes may have a negative impact. So we have to think about this. So again, psychological distress might be related to pain, definitely functional and uh, problems, and may trigger us to investigate more if pain is present. And basically, and especially for the people communicating well, then we can rely on pain intensity scale, at least to have a first vision on what does happen. Also, because just to simplify all that long story, for many people, fortunately, pain is quite a relatively simple symptom to assess, and we may start just by asking to people, are you comfortable today? And then we may explore, of course, a little bit more what are the specific goals of people. But that may make the long story relatively simple in majority of the cases, fortunately. And then allocating specific resources for expanding more on the complexity and of pain in the minority of people where it's really necessary, because then we may discover then something that we didn't realize was making the pain so severe and aggravated and aggravating by other aspects.
Yeah, thank you. Thank you for providing that information. I really like the point that you mentioned of, the relationship between, for example, patient and their healthcare provider or whoever. They're maybe possibly their caregiver, trying to understand, the process of what they're feeling, what they're going through, and to have that subjective lens at the same time. The combination of that is quite complex. And then even earlier you mentioned sometimes it's quite simple. It's just a matter of asking, are you comfortable right now? And of course that comfortability will change between maybe within the day even for that person. And they're like, nope, at the moment this is not what they want to experience. But yeah, I think that that relationship is incredibly important to have. I think with anyone who's trying to communicate their pain to someone else. Um, I was actually gonna just move to a question from the audience over here. We have a question from Shmuel. If you could just briefly talk about what impact of pain, what is the impact, to what extent is there an impact of pain on mental health and social well-being within the aging population? If you just wanted to briefly touch on that.
Yes, that's a very important aspect, of course. And what we do know is that people with mental health disorders are definitely are at much higher risk of severe pain. Not saying that the pain is psychogenic or is created by mental health disorder or is created by depression, but the way people can cope with pain is definitely impaired when they have mental health a condition. So it can definitely be considered as a orange flag in the field of pain, and considering that acute pain might be much more difficult to manage with in the context of mental health disorder. Uh, Not only because of limited coping strategies, but also because of difficult assessment. So when people have a severe mental health condition, sometimes it's even very difficult just to speak about pain, just to try to understand. And then we may have to go back to non-communicating patient pain assessment scale, and there are different, like the IBA scale or others. But that's so pain assessment is definitely an additional difficulty. Another difficulty is that pain aggravates mental health disorders as well. Even if not speaking about one specific condition linked to opioid use disorders or substance use disorder, but just the fact that um, medication requirements and symptoms of, for instance, a dementia, I have mentioned hypoactive, but could be hyperactive also, acute delirium or long-term conditions. All these symptoms can be aggravated by a pain, and not even speaking about other uh, um, conditions like depression, of course. So all these conditions can be aggravated by pain, and then in return can aggravate pain because of the different aspects that I have mentioned. It's even without speaking, but important to mention the risk of pain, not only in terms of depression, but suicidal ideas and finally suicidal attempts. That's clearly a problem in the aging population, and that's simply not acceptable when it's preventable. So we have to accompany these people better and to improve pain, because that's really um, something that people from suffer from, and or may just be afraid of. So no one wants to go to aging in pain, and that's important to have a plan, especially when some progressive condition may make people at risk of, because they may be just afraid of that and going to mental health disorders because of feeling abandoned in a particular condition, when they may say that, oh no, we cannot do anything for you. So that's clearly a bi-directional um, relationship between mental health disorders and pain, and unfortunately a quite universal link between both.
Yeah, absolutely. Thank you for kind of taking us through that. Mental health is incredibly, complex as well on its own, and you know, the back and forth of that is very interesting to take a look at. Um, I know you mentioned earlier that an interesting feature of pain is that it can be described on its own and also described as a symptom of another underlying condition. I was wondering if you could just speak a little bit more on that and how both types of this kind of described pain can be part of a clinical assessment.
Yeah, so I was just a little bit disturbed by the chat as well. So trying to, so please do not hesitate to prompt me if
Yeah,
I'm not
for
uh,
sure.
more. Yeah, but could you just repeat your question?
Yeah, for sure. I know you mentioned earlier that pain can be described on its own and then also as a
Yeah.
symptom of another kind of condition. So I was wondering if you could kind of speak on that and how both types of described pain can be part of a clinical assessment.
Yeah, absolutely. So that's a very important distinction, because all the management may be guided by that. Might be more etiological, of course, if pain just accompanies an acute condition, and then that's quite intuitively logical to think that pain might be a symptom. But it's not only about that. It's not only about just the accompanying condition that may guide the management only. It may also be uh, when thinking about the consequences of pain. So I have mentioned, uh, I think, enough, but the pain intensity, interference, and psychological distress. So the three components of pain. Pain as a disease on its own is typically biopsychosocial. Of course, it's a classical model for many chronic conditions, including chronic pain. But then in that case, we may definitely think about chronic pain as even a syndrome and not only a symptom, but then a combination of these different symptoms and as a condition on its own, especially when it's not explained. So it can be to some extent an exclusion diagnosis when it's not explained anymore by the primary condition. Like a good example is more than 3 months after surgery, pain should have been resolved, but pain does persist. And then pain, which was a symptom initially, becomes progressively a condition on its own and may persist independently on the initial um, condition. It can be after trauma, it can be after many conditions. But importantly, yeah, that's good to re-mention that this biopsychosocial perspective may be an important component of disease on its own, because a disease is not only something, a sign or symptom that a patient may come with, but it's a combination of these different signs and symptoms that can have an impact on people quality of life. And then that becomes a syndrome, that becomes a disease because of having an impact on all people life. Not saying that psychosocial component of pain are sufficient to make it or to allow us to consider that pain is a disease on its own. That does mean that acute pain, even acute pain, but that can be also the case for chronic pain, but even acute pain, where pain can be only a symptom, that can also have, of course, uh, psychosocial, physical, and psychological uh, um, consequences. But when it's a disease on its own, it's most of the time um, biopsychosocial. And when it's a symptom, it can be just only about pain intensity, but it doesn't preclude that the biopsychosocial approach might be also considered. So it's all about the pre-existing condition, if any, sometimes fibromyalgia or diffuse allodynia in the elderly, sometimes, especially in palliative care, sometimes with the conditions where diffuse allodynia and pain everywhere, including just with the pressure on the mattress, and why what is really explaining that kind of painful condition that is not necessarily something that we can identify as a primary cause. So, but yeah, so pain can be a disease on its own, out of the blue or not very well explained, but sometimes it can start with another condition that may resolve while the pain may um, persist. So I do hope that it's to some extent a distinction between pain as a disease on its own, with all the consequences of that, and with a pre-existing condition or not, and but not precluding the possibility for using the biopsychosocial approach in complicated case in acute pain when it's even just a symptom.
Yeah, thank you. Yeah, thank you for making that differentiation and kind of how, one would go about doing a clinical assessment regarding that. It's kind of interesting to understand the dynamics between both. I wanted to just head over to the chat again. We have Anna Maria, I think you had posted two comments. I was wondering if you wanted to unmute and speak to either one of them or both of them.
Okay, thank you so much. I really appreciate it, because I live with chronic pain, and it's very important to differentiate, and he has made some, thanks all for the presentation, excellent. And I want to say, make kind of two different difference of the pain we older adults live with. And one that I live with chronic pain. I have a physical condition. I was told in advance that after the surgery, I could live with less pain or more pain, or in between. But it's how some patients are not prone to take any medication, because there are diverse medication to deal with pain. But some, and the most dangerous I consider, are those who are opioids. So we have to manage the pain or tolerate the pain to the maximum, and when to take the medication. is the danger is when you become dependent. That's the risk for older adults. Because when we are conscious, you have control. But when you are less and less alert, that's when I think it could be it would be very dangerous for the patient. So in older adults, how do you manage that chronic pain? Because it's nothing that we are enjoying. On the contrary, the chronic pain is something that limits our daily lives. So how we manage that?
Yeah,
But
thank
we
you.
have to manage the pain and the medication at the same time. Thank you.
Thank you for your question, Anna Maria. And thank you for sharing that personal anecdote from yourself. I think Professor Forget, if you would like to answer, and then also kind of as a part of that, what are some of the innovations in alternative treatments to opioids, for example? But you can still please address Anna Maria's comment first, if you may.
Yep. Yeah. No. Very important question, because then we touching the, yes, we have improved all this knowledge and we have all this experience, and so what? So how do we will then manage pain? And definitely it's important not to forget the possibility we may have to improve the quality of pain management by maintaining a good access to pain medication. So I'm not there for saying that it should be totally abandoned, but clearly you have mentioned the importance of being cautious, and cautious not to stigmatize people and saying that people using some medications like opioids, or even if it was morphine, and people addicted to these drugs and so on. So definitely not to say that, because it would be a shame then to come with an additional burden or with a stigma. Pain and suffering from pain is already uh, experienced by many to be stigmatizing. People may say that, oh, yes, but you have good days, you have bad days. It's not understandable. And because it's not always visible, also, even with healthcare providers, sometimes we go back to physicians, or I heard myself some colleagues and saying that, yes, but the X-ray didn't show anything, or the MRI didn't show anything, the CT scan didn't show anything, so the pain is probably inexistent, which is totally wrong, of course. If people feel pain, that's quite clear that, yeah, people are not lying. We just have to believe them. So that's an important part of management of pain, is um, being empowered as patient to be comfortable to speak about pain, and to sensitize healthcare providers that pain does exist, even if sometimes it's quite difficult to know why or to measure. So in my experience, in 50% of the cases, we cannot, we just can't have a good imaging showing the source of pain, and we have to accept that as physicians, that with all the science, we cannot necessarily have an objective measure or something in the blood showing that pain is there. So that's the first step. And then you have mentioned very well the double-edged sword that medications are. There are solutions for that, and a solution is, to some extent, and it's not the case for all, but to some extent, is to think about, what would I like to do despite my pain? Or when should I use the medication to decrease pain intensity to reach my goals, what I would like to do, and then using that only if required, and depending on the acceptability of the medication as well, which can be very personal. It's about side effects. If people are a little bit sleepy with the medication, then they won't take that when they want to visit a friend, or to go to the restaurant because they may be sick with the pain relievers. But fortunately, we have many medications not being of the family of the opioids and the morphine and so on, but the non-opioids like the paracetamol, which is not very strong, of course, but sometimes the anti-inflammatories, and that can be also some gels and even sometimes non-pharmacological options. Some people say that warm or cold may help them. So it can be um, different from everyone, and then expanding the possibility to explore simple things that can be non-pharmacological or simple pharmacological things that, for instance, pharmacists may help to explore, because that can be quite different for everyone. And then in average, we do know as doctors what may work better, but that's in average, and everybody's different. And then when touching the simple options that can be pharmacological or non-pharmacological, that also does mean that organizing our days and organizing our networks are also important tools, and everybody has their own toolbox. And a toolbox may include friends, may include pacing, so doing things but more progressively, and then also being tolerant with ourselves and saying that not every day should be Wonder Woman or Superman Day, but we have the right also sometimes to be a little bit more ambitious and to do more, and to accept that the day after we may feel that, oh, it was a little bit too much. Maybe not, next time I will do a little bit less than what I tried to do. And then with all these tools that can be pharmacological, sometimes a strong option, but usually just dedicated to specific goals, short period of time, lowest dose and duration as possible. The non-opioids pharmacological options can also help, maybe more convenient to use with fewer side effects, but also it depends on everyone's condition to be sure that there is no risk of toxicity. But sometimes topical options, and then the social options and how to organize days. Finally, so when speaking about managing pain, also, if I speak about social aspects and how to manage pain and possibly how to prevent pain, we also have um, for specific condition uh, preventive strategies. So that's also important, just to think about a long-term plan with the family doctor, typically to have some counseling regarding what is my health status, what would be good for the next 5, 10 years to try to prevent uh, undesirable condition or progression of diseases, just because I would like to continue to do this or that, and then not to have any issues if it's preventable. So I do hope that it covers different aspects of of the um, of the question, and to some extent saying that we we're not going to a pain-free world next week. Definitely not the goal, and pain is an important aspect of our life anyway, to protect our physical integrity. Just to be warned that hot water might be too hot, and it's good to know that before having burnt skin, but to some extent also not being fatalist and not abandoning the idea that pain may be part of our life, but it doesn't mean that pain has to be unmanageable and accepted every time. Sometimes we have to be resilient and to try to think about how to live with in the meantime, but not considering that it's just something that we have to accept, even if it's not acceptable. So we have the right also not to accept things sometimes.
Thank you so much for that. That was an incredible answer that you gave, and really loved the last statement that you provided right there. Yeah, it's pain is an important indicator. We need to know it as a warning sign, or if something is happening with our body, to kind of take some action regarding that. But also at the same time, we don't want to be living where it's adversely affecting our lives. So we want to be able to manage that. So thank you so much for that entire answer. That was incredible. We also have a question here from Eileen. Eileen, if you wanted to unmute and ask your question, sorry.
Thank you very much, and thank you, Professor, for this presentation. I have a question in relation to, have you personally been involved or familiar with any research on the relationship between exercise and the reduction or the elimination of pain? in particular nerve pain, say on the lower body or the upper body, but also the negative effect of exercise. There seems to be some research on that as well, and you'd want to be able to know the difference.
Thank you so much for the question, because that's very, very important. And exercising, physical activity, but also the mental benefit that it can, and the emotional benefit that it can have on the processes accompanying aging, healthy aging, but also the burden of exercising sometimes when some interference may happen with a condition. So thanks so much, because that's very, very important. So first part of your question, the positive effect. There are plenty of positive effect, of course. I have mentioned emotional, mental, and physical benefit of exercise. I often explain to patients that all the exercises where legs are moving are good for the pain, even elsewhere, and for the mental aspect also, and the mental and consequences of pain, and then going back to uh, physical, social, and psychological interference with pain, but also neurophysiologically speaking, because that's part of your question about the mechanisms of pain and pain intensity itself and nerve function. We do know that activation of the muscles also activate all the processes related to what has been called by some um, the pain matrix, which is a number of connections between different regions of the brain and the spinal cord, and then equilibrating the effect and the activity and the reactivity of the nerve endings. So activating all the system may help. And then sometimes, for instance, people suffering from widespread pain syndrome, fibromyalgia, and saying that very progressively going back to more exercise, even sensitivity to light or sensitivity to noise or sensitivity to others, and potentially also adverse event related to medication. All that may improve when physical activity goes better. That's quite normal, because the habituation system goes better, goes better, and that has an impact on um, sensorial hyperreactivity, and that can be a syndrome on its own, but that's an accompanying symptom in many situations. And if we speak about arthritis, for instance, definitely people being tired and more tired because of the constant pain they may have, and all the impact that it can have, they become sensitive progressively to everything, and then having also other kind of disturbances like um, constantly changing blood pressure and all these different aspects that are linked to um, physical um, function that's progressively decreasing. So progressively deteriorating quality of life and physical activity. So all that can be considered as at least partly reversible thanks to uh, physical exercise. So that's very good. But you mentioned also the potentially bad effect of exercising, and that's important. We have uh, mentioned some goals that people may have. Sometimes being a little bit too ambitious and doing so much that the day after that they may feel broken. Um, that might be an alarm signal, not super dangerous, but just say that being exhausted is not the goal either. And then being over demanding is not necessarily good. Being over demanding for people or for patients, but also as a person living with pain, being over demanding for ourselves might be also sometimes counterproductive, because then being exhausted and paying a price that might be too high for the level of progress that has been observed, and even sometimes if feeling broken the day after. So not the day of the pain, because we can definitely explore and try to push ourselves a little bit more, every day, and 1% every day may mean 100% of progress after 100 days. But if the day after the price paid for that progress is too high, that might be a sign that, oh no, in that case, it might be because of the muscles, it might be because of the central nervous system and the fatigue and being exhausted and emotionally exhausted as well. But it can be the joint, it can be a different aspect where over exercising might be to some extent the later use on a short term, not dangerous on a long term. So let's not be alarming people, but that can be something that has to be considered, especially, and that's the last part of my answer, especially because you mentioned lower limbs. So there are, of course, many different conditions, neurological conditions, orthopedic conditions, um, that or musculoskeletal in general in the lower limb that may affect the pain system, and these effects or these problems, these issues might be partly addressed by doing efforts, moving the legs, because these are typically the ones helping best the pain, but thinking about what's the price I have or I'm paying the day after, and maybe for next time that's a good learning to know that I should go a little bit less ambitiously than what I have done. So I do hope that it covers the good and the bad effect, and also the physical, the neurological, but also the psychosocial and the emotional good or exhausting effect of exercises.
Thank you very much.
Thank you so much, Professor Forget. I think that was an excellent question and a great response to that. And even Anna Maria commented afterwards. She says, "Swimming is in her personal experience has been the best exercise to help with chronic pain." So it's good to know that there are, so many different types of activities that are, have less impact on the body. So it prevents that negative aspect from really happening, but you still get the benefits of, really helping with the pain. So we are slowly coming to the close of to the end of today's Global Cafe. And so before we wrap up, I would love to hear your key takeaways from today's discussion, Professor Forget. So I'll give you a few seconds just to gather some of your thoughts as I'll introduce our next week's topic and speaker now. So please join our discussion next week with Dr. Dawn Milady on the topic of care of older adults and emergency departments. So please join us to listen to that great discussion next week. So now we're back to you, Professor Forget. So in a few sentences, what are some of your key takeaways from our conversation today that you would love for all of us to leave with?
Yeah, so it's very important to remember that pain is preventable, has to be manageable, and is alleviable. We have massively improved the knowledge about pain and how to address that. To some extent, also we know that there is no magic solution, and it's a combination of many different aspects. And to remember that, just to think about the biopsychosocial model. So that's very important, but also we have to continue to invest much time and energy to improve not only safety, but also just access to pain management. And that's first by going back to the patients and listen to them and learn from them. So these are my key home messages.
Yeah, no, that incredible. Great way to summarize a wealth of information that you brought to the session today. So I want to thank you again so much. Before we sign off, I would like to thank everyone for another great week of our Global Cafe sessions. Special thanks again to Professor Patrice Forget for joining us today. And great thanks to the incredible people working at the IFA who have supported this and every Global Cafe, in particular, Ms. Luana Colnago. So thank you again, everyone, and we hope to see you all next Friday and wish everyone a great weekend. So thank you and take care.
Thank you.